So we do post these presentations on YouTube at a later date. You can find the links posted on CompassionNet for those who are affiliated with Covenant Health. If you want to forward the link, it takes about a week or 2 weeks to post after the presentation. If you need the link, you want to pass the presentation on to somebody else, just email me. I can send you the link, or you can find it on the YouTube Covenant Health channel. Please keep yourself on mute. We will address questions at the end of this presentation. We have a lot of people coming in today, very interesting presentations. So we will, anything that doesn't get addressed in the time allotted, what will happen is we'll keep a record of those questions and we'll follow up with that offline. An evaluation is going to be sent out to you right after this presentation, so you can help us a lot by completing that evaluation. I would like to continue with the land acknowledgement. Covenant Health acknowledges that we are located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. I'm going to introduce Dr. Brian Rowe to you. He's a professor in the Department of Emergency Medicine and School of Public Health in the College of Health Sciences at the University of Alberta. He held Tier 1 Canada Research Chair funding in evidence-based emergency medicine from 2001 to 2018. He completed 2 terms as the scientific director of the Institute of Circulatory and Respiratory Health at the Canadian Institutes of Health Research from 2015 to 2023. He edited the textbook, Evidence-Based Emergency Medicine, has authored over 624 peer-reviewed manuscripts, and has an H index of 115. He was elected as a member to the Canadian Academy of Health Sciences in 2015. And with that, I will hand it over to Dr. Rowe.
Okay. Well, thanks very much to Rhonda and the team for coordinating this. It's been a bit of a struggle to get me here and everyone online. So thanks very much for joining. I've been told that I get Covenant Health points for this presentation, not money, and it's all dependent on how many people stay online. So I hope you'll stick with us. I've tried to keep this presentation to about 35 minutes, and hopefully we'll have time for some questions afterwards. So in addition to Rhonda's comment about Treaty 6 territory and the traditional lands of the First Nations and Métis people, the request has been to describe our efforts and our actions with respect to improving the lives and outcomes of people from the Indigenous community. And I've just finished my term as the scientific director at CIHR and helped to run the $105 million 15-year program on training capacity for Indigenous people in Canada. We have trained one of the few Indigenous emergency physicians in a master's program here, and we conduct research that involves Indigenous peoples. So we strive to have respectful relationships to improve the health and wellness of all First Nations, Métis, and Inuit people. These studies that we're going to describe today were funded by the Ministry of Health Government of Alberta through AHS. My own research has been funded for about 15 years by CIHR, and this particular project was funded through the Scientific Directors Grant, which I've documented here. I'm an emergency physician, so I have a keen interest in improving the care in the emergency department. I guess that's my conflict of interest. But the research team doesn't have any specific conflict of interest to declare. I just wanted to start with a little primer about emergency departments in Canada, because this particular project resulted from clinical care that was delivered in the emergency department. Emergency departments are critical clinical settings where care is delivered for patients with complex and life-threatening medical, injury, mental health, and addiction conditions. There's a high ED use in Canada, more so than other um, countries that participated in the Commonwealth survey, and there's an increasing patient volume in Canadian emergency departments. Many Canadians now have no family physician or primary care provider. And in the emergency department, it reaches over 30% for the patients that we see. The statistics are that it's 20% amongst the general population, but many more people come to the emergency department without primary care follow-up available to them. And that's a real problem. In Canada, in the Commonwealth survey, we had the longest time to access just-in-time primary care, which means that the emergency department now becomes a default for patients with many problems that could potentially be cared for by their primary care provider. And when I graduated from medical school in 1900, there was, elective admissions to hospital, but many of those are restricted now to scheduled surgeries, and the majority of patients come through the emergency department to be admitted. You might recall this particular show called ER, and this is what we were hoping would happen when patients came to the emergency department. We'd rush to their aid and they'd be seen almost immediately. It has occurred in the past, and it has occurred in some countries, but not currently in Canada. You can see that several of these people became quite famous. This woman, I don't know if you can see my arrow, but this woman has been a very successful actress on television series. The man on the far left has been voted the sexiest man alive for many years. Also had a very successful career. The other three we've not seen before, but I'm convinced they work at the Tim Hortons across from the hospital here. Not everyone was successful. This is largely how it works in Canada. There's a long waiting time. In fact, yesterday I worked till midnight, and emergency departments around the city were advertising 8 and 9 hour wait times. So the system is struggling with many problems, and currently we're existing in a situation like this. It's important to recognize the conceptual model for overcrowding in the emergency department. Why are we so crowded? There's a four-pronged approach looking at input, throughput, and output, as well as system-wide influences. On the input side, people come in by air and land ambulance. They self-refer, they get transferred from other hospitals, and they're referred by specialists and primary care providers. For services that are available in the emergency department, like fracture reduction, laceration repair, more formal evaluation of symptoms than a primary care provider or specialist office can do in the short term. In the throughput area, we triage patients with nursing expertise. We provide immediate treatment for some patients. More commonly, the CTAS 1 and 2 patients. Patients get assessed by a physician following a nursing assessment. We do a history and physical. Labs and images are ordered when indicated. We start treatment and monitor the patient, and then we develop a management plan. So a lot of the throughput is the responsibility of the emergency department. And then the output, patients can make decisions to leave without being seen and leave against medical advice. We're particularly concerned with left without being seen. It's at a very high rate in Alberta, particularly at the tertiary care hospitals where it's over 10%. And those people represent patients who've had an initial assessment by the nurses and vital signs, but we have not seen them formally in the emergency department. People who leave against medical advice often do so because of the initial delays in being seen and time for lab and imaging. Patients can be admitted, and that varies considerably across the city. We have about a 1 in 4 admission rate at the University Hospital, whereas at the Sturgeon, it's about 1 in 5. So, 1 in 20. And so, various differences exist across the system. Patients can be referred back to their family doctor when they have one, or to a specialist if the condition can be followed up in an acute setting. Some patients are transferred to other hospitals, and fortunately, death is fairly rare. The system-wide influences are things like the payment models that exist for clinicians, the system of deferral, ambulance services, those kinds of things are system-wide influences that impact crowding. So the consequences are that ED overcrowding is at an all-time high in Canada. It's representative of a wicked problem in the healthcare system with many different causes and contributors. Who's to blame? Governments often blame patients for overuse and misuse. And I'd like to just state categorically that the majority of patients don't misuse the system and are mainly concerned with their symptoms and receiving a diagnosis and treatment. Governments also blame administration for inefficiencies, whereas administrators often blame clinicians and government, particularly government funding. And we can say without fear of contradiction that we have some of the lowest bed to population ratios in the world in Canada, and this has been considered a significant problem. Clinicians will blame anybody. Largely, they blame governments for underfunding the system, and prolonged delays for care lead to worse outcomes. Majority of Canadians deserve and demand better, and so pointing the finger hasn't been a particularly successful intervention. It's important to recognize that there's been a lot of research on overcrowding, and one of the things that's important to realize is that when people are sick, and that's CTAS scores of 1, 2, or 3, if we look at the people who are discharged or left without being seen, who have very low acuity or high acuity and low CTAS score, if you look on the left-hand side, this is the number of hours the average person would stay when that person showed up. And what you see is death is higher the longer you wait in the emergency department. Admission is higher the longer you wait in the emergency department. And perhaps the best decision that people make is leaving without being seen. They have a lower death rate. So the longer you stay in the emergency department, perhaps the longer you're exposed to infectious diseases and contacts. But whatever's happening is statistically significant and clinically important. Even when you look at the patients who have CTAS scores of 4 and 5, which the government would argue, those patients don't need to be there. The same pattern exists. Death is higher the longer you wait in the emergency department at that time, maybe because you see a large body of people in the waiting room, you make the decision to leave without being seen, and that's a bad decision. But admission to hospital is also statistically significantly important when you look at the delays in the emergency department. So again, the cause of overcrowding is multidimensional, but the outcomes are poorer the longer you wait. So I don't want to go into any more details, but what we've been trying to do is identify the problem areas and possible solutions. So I'll give you a case presentation as an example of why we got involved with this research. We had a 40-ish year-old male brought in by EMS on a Sunday morning to the C-Pod in the University of Alberta Emergency Department, accompanied by his family. He'd had a 2-year history of glioblastoma multiforme, or stage 4 brain cancer, which is largely palliative from the start, but he had received debulking surgery twice, chemotherapy and radiation. At this point, he had deteriorated to the point where he was pouching his food in the side of his mouth, and the family was pushing the food to the other side where he could chew. He was unable to ambulate due to left-sided arm and leg paralysis. He was bedridden, and he was being cared for by his adult daughters and family members. He had some home care, but at the end of the day, the family was trying to provide care for him. The family understood this to be his new normal, quote unquote, and were unaware of his imminent death and palliative condition. The CT scan showed a midline shift and severe edema despite the fact that he was receiving dexamethasone. And he was sent in on the weekend by the oncologist for palliative care referral. And as most of you will know, palliative care referral doesn't need to be done in the emergency department. And in fact, the palliative care services likely should have been engaged at a much earlier stage. Fortunately, we were able to secure a bed the next day in the Grey Nuns Hospital palliative care unit. He received excellent care until his death approximately 10 days later. And the family provided a video, educational video for AHS regarding the introduction of palliative care in the emergency department. It was the beginning of a body of work that we started on palliative care and end-of-life care in the emergency department. So as we've improved our care of patients with COPD, myocardial infarctions, we've been seeing an increased number of patients with end-of-life conditions in the emergency department. Identifying and assessing the management of patients with end-of-life conditions has been pretty sparsely investigated, and I think it can help identify gaps in care. And I hope you'll see from the work that we've done that we've advanced that area. And the question is, what do we do next? We chose end-of-life conditions because there's a variety of them that are being seen in the emergency department. And we define palliative care traditionally as care to minimize pain and suffering for individuals across all age groups with severe and life-limiting health conditions. We didn't do pediatric end-of-life care and palliative care because the hospitals that were involved don't see pediatrics, but I know from discussions with my pediatric colleagues that this is also a concern. And many emergency departments offer palliative care consultations or referrals. It's more available in some hospitals than others. So the concerns about the emergency department as a location for end-of-life care and palliative care is that it's a suboptimal setting for discussion regarding end-of-life and palliative care, especially the goals of care. These are often loud, chaotic environments where interruptions occur on a frequent basis, particularly for the clinicians who are responsible for incoming patients. Most ED clinicians don't have pre-existing relationships. The pre-existing relationships that we have in the emergency department are not patients that have end-of-life care in general. Frequent flyers exist, but the relationships aren't developed to the point where we can provide patients and their families with a sense of comfort with the decisions that are being made. And ED clinicians are often uncomfortable with this role. We've done some research with the ED clinicians, and although they're developing these skills, this is not something that would be center and core for their training and development. So we were approached by the SCN Critical Care and Cancer Networks in 2018, and as well as Alberta Health Services. They wanted to better understand the frequency and characteristics of patients presenting with end-of-life conditions. One of the problems is this is not well documented. It's not a diagnostic code in the administrative data, and it's really hard to determine who has end-of-life conditions and might need palliative care. And so we just decided as a research team to conduct an observational cohort study to identify these patients in the emergency department. And we completed that study and several additional studies that I'll describe here. Our first project was the main project, was published in Journal of Palliative Care. It's an open access journal, and I sent that article to Rhonda, and hopefully if you're interested, you can review that. And we did two secondary analyses, one on patients with met and unmet palliative care needs, and then with patients with cancer. So the first project was designed to identify and characterize all the patients presenting to ED with end-of-life conditions. It was approved by the Research Ethics Board at the University of Alberta, Alberta Health Services, and Covenant Health. I will say that my experience with Covenant Health over the years has been it's a very efficient approval process, and we appreciate the dedication of the staff in Covenant Health to including us in their research programs. We approached emergency physicians at the University of Alberta and the Grey Nuns community hospitals and asked them to volunteer to participate in the study. They signed informed consent, but the patients did not sign informed consent. There was no additional services provided to the patients or tests done as a result of this study, and we were able to obtain consent from all the physicians involved. We used a modified screening tool to identify patients with unmet palliative care needs. Again, if you think about the emergency department, it's busy, and physicians are not going to fill out 10-page forms for our research project. So we wanted to develop something that was efficient, that gave us information that we could supplement with chart review. And we had a research staff member assigned to both the Grey Nuns and the University Hospital. They've been part of the publication group, and I'll introduce those at the end of the presentation. So the physicians completed a screening form on the designated emerge shifts. So we tried to collect shifts that were overnight, weekends, days, and evenings. We supplemented that with EDIS and chart reviews. The data was entered into REDCap, which is a safe and secure data entry tool that is was developed by Vanderbilt University in Nashville, Tennessee, and is one of the preferred products available for researchers through WICRE's license. And we did duplicate data entry, extraction and entry on a small sample to ensure that we were identifying disagreements. All the data was de-identified and reported in aggregate. And this is largely a descriptive study, but we do have some regression analysis for major outcomes. This is the form that we used, and you can see at the top the specific diagnoses. So the doctor would check the box, and then we looked for unmet palliative care needs. I'll discuss that in the future. We also asked a few questions about language barriers and goals of care. On the back page, we had definitions for example, for chronic obstructive pulmonary disease. If you have mild COPD and you've stopped smoking, that's not an end-of-life condition. So the MRC classification of people who have such severe shortness of breath that they can't walk 100 yards or are breathless leaving the house, those are considered end-of-life kind of conditions. And we left definitions on the back page of the one-page form. So how did we do with recruitment? Well, if you've never done an emergency medicine study, 75% of physicians accepting the challenge of participating is almost unheard of. So there was what we considered to be a general interest. 45 of the 60 physicians at the two sites agreed to participate. We tried to get physicians to do 3 to 4 shifts. We often had keeners who would do up to 8 shifts, and others who consented to participate and did 1 or 2 shifts. But we got a large range there. There was the population was more male than female. Average age was about 41 years. These are largely seasoned clinicians. About 50% of them had more than 10 years of experience. We did look at junior staff versus senior staff and didn't see major differences in their performance. And so we think that we had a pretty broad representation. And over the course of all of these shifts, the physicians saw 26,328 patients, of which 663 were considered to have end-of-life conditions. And again, you see a fair variation here. The University Hospital had more than almost 5%, and the Grey Nuns had about 1%. Again, the tertiary care, quaternary care component of the University of Alberta Hospital, the specialist groups that are here, particularly in respiratory, cardiac, and GI, likely attract a larger proportion of patients with end-of-life conditions. We are generally considered the emergency department for the Cross Cancer Institute, and hence we get a lot of the patients from who are suffering acute illness from that center. So here's the study flow. It's important to note that the exclusions included all the patients had no end-of-life presentation. So the majority of people didn't have a condition that would be considered end-of-life. Presentations were reviewed by the research staff, and about 58 patients were considered to be potentially missed. So again, less than 10%. Some patients were so sick that they died on arrival, so we didn't have the information, and the physician was not expected to produce the form for that. And then some people who presented in shock and severe sepsis, we had made an exclusion for that group as well. Not a lot, but some patients. This is rather small, and I apologize for that, but I'm just going to highlight a few things. This is an elderly population, average age or median age of 76, about equal proportion of males and females. The most common end-of-life condition we dealt with was cancer, but COPD is also common, as is dementia. And when you look at single versus multiple end-of-life conditions, about 1 in 10 patients had more than one end-of-life condition. These patients come in fairly sick. CTAS-2 of 41% is much higher than the general population in the emergency department. Most common symptom was shortness of breath. Goals of care were documented on arrival in 2/3 of the patients. And when we looked at unmet palliative care needs, about 78% of people had unmet palliative care needs. Finally, the challenges that were presented by these presentations were things like language barrier and dementia. And again, this prolongs the interaction and the discussion about end of life and palliative care with these patients and their families. The management was pretty complicated. Patients stayed in the emergency department for approximately 11 hours. 60% presented by EMS. 77% received a consult to either internal medicine, family medicine, or one of the other services. Patients received medications, including narcotics and antibiotics and fluid resuscitation, antiemetics for their symptom control. And most of them received investigations, including imaging and advanced imaging like CT scans and MRIs. So these patients are receiving extensive care. They're often very sick. They're elderly, and they are taking a lot of time in the emergency department. What were the outcomes? Well, 65% of them are admitted. And remember, I said 1 in 4 at the university hospital are admitted on a general basis for all comers. 1 in 20 at the Sturgeon as a comparison. Well, this is 6 out of 10 or 3 out of 5. That's a huge difference between the average population. Many of them were referred, and the referrals went to things like home care specialists and palliative care. Interestingly, most of these patients, or a large majority of these patients, had visited the emergency department in the previous 6 months. About a third of them represented within 30 days after they were discharged or admitted to the hospital on that index visit. And there was a high death rate. As I said before in the conceptual model, that's not a common outcome for the emergency department. And death by condition, cancer was the most common condition where death occurred within the emergency department or the hospital. So overall, this is the first observational cohort study that was prospectively developed that estimated the number of patients with end-of-life conditions. It was about 2.5%, but as I said, site variation exists. We don't have a good handle on how that would compare to the ALEKS, the MIS, the Sturgeon, the Strathcona, any of the other hospitals in town. These patients are elderly. They undergo frequent investigations, imaging, consultation, and 2/3 of them are being admitted to hospital. Since about 70% had previous ED visits, our sense is that we could identify these patients earlier in their course and provide them with access to services that would perhaps reduce their ED visits and improve their outcomes. And a large number of these patients had unmet palliative care needs. So that's the first study. And what we decided to do was look at these patients with the unmet palliative care needs. And just to recap, we required the patient to have one end-of-life condition at least, and at least two answers to the unmet palliative care needs. And there's a whole body of work that's been done on screening for this. But if you had two or more ED visits or a hospital admission in the past 6 months, visit today prompted by uncontrolled symptoms, functional decline like my patient with the loss of mobility, these kinds of issues, uncertainty about goals of care. Again, this family had uncertainty about goals of care. And a surprise question, would you be surprised if the patient died within 12 months, or you would not be surprised if the patient died within 12 months? And so if you had at least two unmet palliative care needs, that's considered an unmet palliative care condition, and you had to have the end of life. So again, when we looked at this, a large proportion of the patients had unmet palliative care needs. And again, when we look at the characteristics, there's not really much difference between the two groups, met and unmet palliative care needs. They're very similar in their age, arrival, CTAS score, goals of care. The results of the screening tool is that more people with unmet palliative care needs had more than two end-of-life conditions, 14.7 versus 6%. We list out the screening tools, the positive responses, and many of these had, obviously they had at least two, but many of them had more than two, and functional decline, uncontrolled symptoms, and previous and frequent ED visits or hospitalizations were the top three. The surprise question was positive in 80% of these cases. We looked at goals of care and looked for whether they were appropriate or not. And generally they were congruent between met and unmet needs. And then what were some of the other issues? They seemed distributed. You couldn't explain the unmet palliative care needs on the basis of the diagnosis or the language barrier. Again, here you see virtually no differences, except the fact that patients received a consultation request in the emergency department more commonly if they had unmet needs. But the medications used, the procedures performed, the investigations performed seemed pretty similar between the two groups. And then the outcomes, well, more of the patients with unmet needs were admitted to hospital, and fewer were discharged, obviously, and they had a higher mortality rate. Patients with unmet needs had more ED visits than the previous 6 months. And we did logistic regression analyses, and when we adjust for sex and CTAS and all the other important factors, it's clear that the unmet palliative care needs patients had more common presentation with two or more end-of-life conditions. They were hospitalized more frequently, and they died more frequently. So again, here's an example of the unmet needs are representing poorer outcomes for patients. And then the conclusions for this, a significant proportion of patients presenting to Alberta EDs with end-of-life conditions have unmet palliative care needs. Patients with unmet palliative care needs are more likely to undergo consultation, require hospitalization, have a history of ED visits, and die during their index visit. And having multiple conditions or requiring hospitalization was strongly associated with having unmet palliative care needs. So our final analysis of this data set was related to advanced cancer. So cancer was the most common reason for presentation of end-of-life conditions, and we wanted to look at differences in management or characteristics. And again, the same sample, we had advanced cancer as 272 of the cases versus 391 with other kinds of conditions. The advanced cancer patients had similar single cancer diagnosis and comorbidities of other end-of-life conditions as the group that didn't have cancer. And again, the remarkable feature here is that there's a lot of similarities. The age was slightly lower in advanced cancer. Fewer of them have arrived via EMS, so likely longer duration of conditions, better education that would explain that. They had more common presentations of abdominal pain and fever and less presentation with shortness of breath. But again, many of the conditions were very similar. Again, the management was considered identical. There's virtually no major differences here, and we adjust this for multiple tests. And when you look at palliative care needs, the surprise question was higher, positive higher in the advanced cancer group. The patient having a goals of care were less frequent in the cancer group, and the goals of care on arrival were less commonly documented. So one of the problems that we have in the emergency department is people may have advanced directives, but we don't have the goals of care present in the emergency department. Particularly at this time when the study was done, we weren't on Connect Care across the region or across the province. If the patient didn't bring in or the family didn't bring in a green sleeve, even if it was goals of care were discussed with the patient, we didn't have evidence of that in the chart. And again, that's a big problem in the emergency department where interventions are being immediately implemented at the bedside. And so sometimes we get the sense that we're doing something that the patient is not particularly approving of, and we don't have the documentation at the immediate presentation. Again, the outcomes, referrals were higher in the advanced cancer group, and palliative care was the most common referral. Again, we looked at logistic regressions analyses to see if adjustment would explain this, but the factors associated with length of stay and the factors associated with admission were very similar, and the cancer patients more commonly presented with more severe disease by these analyses. So the conclusion from this was that the cancer patients with advanced end-of-life cancer were less likely to have clear goals of care. They tend to be younger, more likely females, and slightly longer lengths of stay. They consume considerable resources and are admitted frequently, and they're most likely to receive a post-referral, post-discharge referral for palliative care. So this collection of projects, again, there's limitations associated with this kind of research. Not all emergency physicians participated, not all emergency physicians participated equally, even though they consented. We think based on the chart reviews, there were some patients that were missed who had advanced end-of-life conditions, and so likely this underestimates rather than overestimates the condition. We didn't verify the end of life condition. We trusted the clinician group to be able to identify those patients. And like we said, less than 1 in 10 were missed. So we trust the assessment provided. We had a relatively large sample size, but in some cases, the sample size was large enough to detect small differences that maybe aren't that clinically important, and that's where the future discussion is planning to head. We had some pretty poorly documented outcomes. I think the Connect Care development is going to help with that particular issue because now it's all typed in and documented across the region and across the province. And there are obviously we don't have a standard admission for end of life and palliative care needs on Connect Care, and so we didn't have standard reporting by the clinicians at that time. So we may have missed some issues. But overall, I think this work has provided important and relatively novel information on the presentation of patients with end-of-life conditions. We're really pleased with the participation by the two sites. We chose the Grey Nuns because it had a palliative care unit and the University Hospital because it was the quaternary care hospital for the region. Again, like I said, we don't have data on the other sites in the city. And this was a relatively time-consuming and expensive study to conduct. We've identified some gaps in end-of-life care with respect to lack of consultation or referrals to available palliative care services. There are definitely inconsistencies with the goals of care documented and identified. And this may have improved over the pandemic because there was a big push to document goals of care during the pandemic in the event patients with end-of-life conditions contracted COVID and were brought to the emergency department. So this may have improved. We don't have any research on that at this point. While we've done some work on the abstracts and publications and we've reported back to the funders, there's been a relative pause due to the pandemic and also the restructuring of AHS into 4 distinct subgroups that has really sort of blocked further discussions about interventions to improve what we found from this research. We did do some additional research as part of this body of research on palliative care and end of life. We did a qualitative study that's recently been published, the systematic review on interventions for patients with advanced or end-stage illness. And then we did a systematic review on the screening tools, including the most important one from the literature, which is the surprise question. So this is the collaborating group on the end-of-life study team. Miriam Garrido-Clau is a researcher originally from Barcelona, and she's since returned to Barcelona. Maureen Krulak was a undergraduate student that was working with us. She's now a veterinarian. Not everybody left, but over time we've lost some people. Christina Villarroel is a PhD student of mine who graduated, worked with us, and now is living and working in Regina. Shelley Duggan has become the president of the AMA, so nobody sees her anymore. Barb O'Neill was a nurse who was the dyad partner on the SCN, and the SCNs have largely been terminated. Adam Elwey was a PhD who worked with us. Many of you will know Amanda Brisebois, who is an internist who has particular interest in palliative care medicine. And then finally, the two who've remained as consistent members of the research team are Scott Kirkland and Esther Yang, who are Scott is a systematic reviewer and ran this project, and Esther is a database management expert who helped us with the outcome assessment. So I've been asked to leave some time for questions. So thank you very much for listening. And I'll hand it to Rhonda. I think she was monitoring the chat, and I'm happy to answer questions from the audience. And as Rhonda said, if your question is not answered before in the next 12 minutes, we will try to get responses back to you and sent out by email. So Rhonda, I'll hand it back to you and I'll stop sharing. How about that?
Perfect. Okay, so we do have a few questions in the chat. Feel free to post your questions in the chat or feel free to raise your hand if you want to come off mute and ask it orally. The first question, and I'm not sure which study or which project this refers to, but it is how many were actually admitted to palliative care? Is that known? The number known?
Well, I can tell you from personal experience, it would be very, very small numbers. I mean, the palliative care service is relatively small in the city. The number of palliative care beds is small. What generally happens, at least in our site, and maybe Pat can tell you what happens at the Grey Nuns, but the patients with end of life and palliative care needs that need to be admitted who aren't getting active treatment often go to family medicine or internal medicine. And those beds can be spread all over the hospital. The number of beds, I think, for palliative care in the city is insufficient. So it's a small number. I don't have it, exactly, but it was inconsequential. It wasn't a large number. Even when they got consulted, they often didn't have beds.
Okay. What are some upstream approaches we should consider to reduce the proportion of those presenting to ED with EOL conditions?
Yeah, that's a great question. I mean, I think we've been in discussion with the colleagues that have the largest proportion of patients in these groups, and I think having the goals of care advanced directives developed and discussed with patients prior to their crisis is really important. There's even goals of care that can be used in the EMS setting for patients. So, again, when we know the goals of care, we can provide comfort and not do interventions that patients and their families don't want. So that's a critically important one. There are interventions that have been applied elsewhere. For example, many of these patients have, from the cancer perspective, have febrile neutropenia, anemia with syncope. Those kinds of conditions often require emergency treatment because there are no sort of subacute treatment approaches available. And the Cross Cancer Institute is often very full, like many hospitals. So those kinds of interventions are the kinds of things that I think we need to try to innovate and bring forward. I'm just giving a couple of examples. There's likely others elsewhere. I know that Panita Tandon's group is trying to have the patients with end-stage cirrhosis being seen in the GI clinic for their paracentesis, and that's a really important contribution. I know the pulmonary group is trying to develop a program for pleural effusions. So these outpatient settings can sometimes be really helpful to decrease the overall presentation to the emerge.
Okay. You'd mentioned that there is no end-of-life diagnostic code. Is there a need for one long term?
Yeah, I mean, I don't do the coding, but sometimes they can adjust that. It's very difficult for that to be part of the coding system because it's really a severity of a condition. They most commonly use the condition COPD, let's say, as an example. There's a code for that, and that's what the physicians and and the medical record nosologists, but most coding systems don't look for the severity of the condition. So I personally, I don't think that's where the money is in this. There's another, some things that you could do to examine this problem. You could look at all patients who present with one of the conditions who have a 1 day stay or die in the hospital very quickly. It's one of the studies that we've thought about doing. And if a person has a 1 day stay and dies for a condition that they've had, in the past, like COPD, heart failure, kidney disease, then I think the assumption could be that that is an end of life. I mean, obviously their life ended, but those kinds of ways of looking at it might be a way to avoid the coding issue. You can look at administrative data that way.
What about being admitted to palliative home care? Was that assessed?
Um, we do have uh, a record of whether a palliative care consultation has been done in the community. So there is some evidence that patients with end-of-life conditions have had that. I can't tell you the exact number.
Okay, and a bit of a long one here. So thank you for this important presentation. Are we able to put in palliative care community consults for patients? And are they able to address some of these issues, such as GOC conversations? By that, I mean consult for outpatient PC from the ED. I have been told to ask patients to see their PCP for this.
I haven't done palliative care community consultations myself, and I'd have to look that up. That's a great question, and maybe we can answer that, Rhonda, in the subsequent email. I do think it's available. I just don't know how effective it is.
Okay. And one more. What is your take on discharge to home care and the effectiveness of care at home?
We didn't really study the effectiveness, but my own personal feeling is that we have, I refer frequently to this home care for a variety of reasons, and I think, it's one of the areas that we probably need to expand in emergency medicine and medicine in general. Excuse me. I find them very responsive. They give good support to patients, and often that can prevent emergency department representation. I mean, a good example is wound care. When we do an abscess drainage in the emergency department, we refer to home care for wound dressings. Many of those patients never return to us. In the old days, they have to come back to the emergency department to get the wound care for the next week or 10 days. So there are strategies in place that can reduce emergency department representations. I think, home care is a perfect example.
Okay. One more. Given the outcomes, what further research would you recommend in this area?
Well, as I said, we've been looking at additional ways to identify these patients. So I think that the early, discharge, the admission to hospital with a death within a very short period of time, maybe 24 to 48 hours, with a previous diagnosis would be an important contribution. We've done some work with emergency departments about this. I think the next step would be looking at ways to have these patients identified early and whether people would be receptive to that identification. We see these patients all the time, and somehow getting that early referral, I think, would be worth examining in the future.
Okay. I'm not seeing any more questions. I'm seeing thank you, Brian. Excellent presentation. I don't see any hands up. So at this point, I would like to thank you, Dr. Rowe, for the presentation. I will send out an evaluation. Also, a reminder that the recording of this presentation will be posted on the Covenant Health YouTube channel in case you want to share with somebody who wasn't able to attend today. And if you have any further questions for Dr. Rowe, please don't hesitate to send them to me and I can make sure that he sees them.
Okay, thanks very much.